So today's webinar is a focus on healthcare security in focus, causes of violence and strategies to diffuse and prevent it. And so this will formally start our recording for today's webinar. So on the next slide, just an acknowledgement. So this webinar is presented by the Region 1 Disaster Health Response System, RDHRS, in collaboration with the Regional Emerging Special Pathogens Treatment Center, or RESPTC. Both of these programs are funded by the Administration for Strategic Preparedness and Response within the Department of Health and Human Services. And so just a disclosure that the content that we're providing in today's webinar is presented by individual speakers only and does not represent or reflect the policy or position of any portion of the United States government, and that this content is not meant to substitute for medical professional advice, diagnosis, treatment, and that the information here should be adapted to specifics as appropriate. Obviously, today we're going to be focusing less on clinical information, but important for us to caveat in that our speakers have no affiliation or financial interests/relationships to disclose. And so very excited today. We'll do quick introductions and then I will turn it over to our fantastic speaker. So my name is Jen Shear. I'm the Vice President of Emergency Preparedness for Mass General Brigham. And I'm very excited to introduce today's speaker today, who is nationally renowned in the work that she does and is very much an esteemed colleague, Bonnie Michelman. And so for background today, Bonnie is a nationally recognized speaker in security management. Bonnie currently works as a consultant, speaker, and litigation expert, but her career includes decades of influential leadership. She previously served as the vice president and the chief security officer for Mass General Brigham System. And it's under Bonnie's leadership, MGH earned the Lindbergh Bell Award for the nation's top health security program 3 times. So in 1999, 2007, in 2018, and really her impact extends beyond healthcare. She was appointed by Jeanette Napolitano to the Healthcare Security Advisory Council, where she served for 6 years. Bonnie has also spent 25 years teaching at Northeastern University's College for Criminal Justice and has consulted extensively on topics like health security, workplace violence, hate crimes, and risk management. She's also a published author, an executive coach, and has served as an expert witness in security litigation for more than 20 years. Her academic credentials include an MBA, an MS in criminal justice, and a BA in government and sociology, along with a CPC and CHPA certifications. And so please join me in welcoming Bonnie Michelman, and I will turn it over to her for today's fantastic presentation. Apologies, I'm going to turn over to Bonnie in one more second, just learning objectives quickly. What we hope to go through today with our webinar is to describe the current threat landscape and factors contributing to increased violence in the healthcare setting, to identify common causes and triggers of violent incidents within hospitals, and then finally to implement practical de-escalation tactics and proactive security strategies to reduce risk and maintain a safe environment. And so with that, now I will turn it over to our esteemed speaker. Bonnie, take it away.
Thank you, Jen. And hello, everyone. Thank you very much for being with us on your Friday. I know it's not always easy, and I'm thrilled to see so many of you here. Next slide, please. There's not one way to talk about workplace violence, particularly in healthcare. It is an epidemic. It has been a tsunami. That's the bad news. The good news is we're finding lots of different ways to mitigate and to reduce it. I have consulted at several hundred hospitals across the country and some abroad. And I left MGB recently, at the end of the summer, to do more consulting. And what I have found, even in the very best of places, is nobody has this perfect. Nobody has this one-stop solution to eliminating violence in healthcare. It's certainly not something that can easily be done. But a lot of people are having a myriad, a diverse approach that I think works. And I think we tried to do that also at MGB. So I'm going to talk a little bit about this. But really the definition of healthcare violence is how someone else would define it. And maybe they define it by just feeling scared. Next slide. I don't have to tell all of you, and I know a lot of you are in emergency preparedness, But I think that is so closely aligned. There's so much synergy between security, risk, emergency preparedness. So the more you know about it, the more you can work closely with your security colleagues, the more you have to do some security related initiatives, and the work that you do, which is so incredibly imperative and critical, can be done even better. These are the unique nuances. People have said to me over the course of my career, which is several decades, many years at MGB, years before in other industries doing security leadership and management, what's so big about healthcare? Security. Why do you need it in healthcare? By far, violence is the most prevalent in healthcare than any other industry in this country, by far. The good news is active shooting in healthcare is the lowest of any industry in this country. It's not the same as it is in theaters or churches or schools or synagogues. It is the lowest, so that I guess is good news. But all of the factors on this slide can show you why it is really, really tough in healthcare. You've got people that are very ill, very scared, very impaired. You've got staff that are working extraordinarily hard under difficult conditions. You've got a microcosm of a city. This is the only industry where you can't say to people, no, you can't come in. Everybody gets to come in, and everybody, no matter what their behavior, if they're extraordinarily sick, gets to stay in. And that creates a lot of tension, and it creates a lot of ability for tough things to happen. The good news is most of the things that happen are foreseeable, and that's what we're going to talk about, is how you can take care of these foreseeable risks. But sometimes things are unforeseeable everywhere. People tell me all the time, well, shouldn't we have a zero tolerance policy for violence? And I often say that's ridiculous. You should have a zero ignorance tolerance for violence, but nobody has a zero tolerance because there will always be some violence in healthcare. Next slide. The types of violence and conflict, you've seen this if you work in healthcare at all or read the paper or watch the news. The ones that are bolded there on this slide, verbal abuse, threats and harassment, intimidation, bullying, I would say, and some assault and battery are the top. They are the ones that are most common, particularly verbal abuse and threats and harassment and discriminative behavior, which has become very prominent and popular over the last many years. Hate crimes has become a bigger issue than it ever was. Domestic violence has always been a big issue, particularly where healthcare is predominantly female-based in terms of staffing. But intimate partner violence is can affect men as well as women, and we're seeing that in hospitals every day. Cyber, we didn't talk about cyber attacks 20 years ago. Now we're talking about them in a big way. There are thousands of cyber attacks in healthcare in this country every week. There's actually 5 attacks a week that are ransomware attacks, which is a statistic that blows my mind. So certainly when people say, do you really need security in hospitals? The answer is absolutely. The great news is reporting has gone up. I remember when I started in this field, when I started at MGH, Mass General Hospital, before I was in the system role, but we didn't have a system back then. But I was very concerned because people did not report things that were happening to them. Nurses would get kicked or pinched or called names, and they just felt like it was part of the job, nursing and other people. And we have spent a long time, a lot of us, trying to make sure that people understand that they should and need to report anything that occurs that is not appropriate behavior. And the more they do that, the more we can address it, the more we know what our problems are, the more we can get supports to help them with particular patients or family members, etc. Next. All areas are vulnerable, but these are the big ones in healthcare systems. And not only in hospitals, but in step-down units and skilled nursing facilities, in smaller places, in urgent care facilities, and eye care facilities. It's very important to know that sometimes those satellite facilities can even be more at risk because they're not the mothership. They don't have perhaps a security department there or even security officers. So that in that case, there needs to be good technology, good communication systems, a good code system, and people who are trained. Training is most important. But these are some areas, obviously, with emergency departments. These are in no particular order, but emergency departments by far in this country have the most amount of violence and chaos and threats and sometimes assaults. But we've seen, parking garages have the most amount of sexual assaults and robberies than other places. Women's health, we never had to worry years ago about clinicians who are working on women's health or reproductive rights. We have to worry about that today. We have to worry about people doing transgender care, gender affirming surgeries or care. Those people are being targeted, which is, such a tragedy. But there are constantly changing vulnerabilities. Our pharmacies sometimes have more than street value drugs in all the CVSs in a city. So we have to be very careful. And with those of us who have large research facilities in a variety of areas, there's a lot of potential dissidents out there that may not be happy about AIDS research or animal research or other or Alzheimer's research or research that uses select agents. So there can be a lot of vulnerabilities there. Next slide. Here are just some trends that I've really some themes that I've put together over the last few years. One of the issues I see a lot, and particularly I do a lot of risk assessments in healthcare facilities across the US, and people tend to be either complacent, they don't care about their security, they don't think about it, they don't want to use technology, or when there's an event that occurs, or when they read something in the paper, or when there's been something on social media, they get scared. And they say, why don't we have security people on every floor? Why don't we have metal detectors, et cetera? So it can go from complacency to overreaction. And my philosophy is, as a security and risk leader, that people need to be in the middle of that continuum. They need to be empowered, they need to be trained, they need to be confident, but not going back to complacency and not going to an overreaction. Because when an overreaction occurs, sometimes there are solutions that don't make any sense because people are just emotionally scared. There's increases in volatile behavior and conflict. We saw huge increases after the pandemic. I think because there were less psychiatric facilities, there were more people that were, emotionally and mentally affected by the pandemic. And there were a lot of people that didn't want to work in healthcare anymore, frankly. So there was some staffing issues in various types of departments. Recent national incidents, and even if they're rare, promote a great deal of fear, sometimes fake information too, and unrealistic expectations about what can happen. I remember a board member asking to meet with me, who was very upset we didn't have armed security on every floor in our hospitals. And I asked him to come in and meet with me, and we had lunch, and I explained to him how security works and why we can't do that on every floor and why it would not be practical or financially possible, or even from an optics perspective, important, and what we do to ensure, even from behind the scenes, that we are lowering the risk. And he really understood it after that, but a lot of people don't understand. And for whatever their own backgrounds are, may get extremely agitated when they see something on TV that happens somewhere else. Injuries from assaults and attempted assaults are often very low. There's a lot of attempted assaults, there's a lot of verbal abuse, but in many places, and Mass General Brigham was one of them, actual injuries from assault were a tiny percentage of the actual abuse and sometimes attempted assaults. That could be because there's, good training, and that could be because people are a little lucky. That could be because people threw a glass of water or coffee and it missed them or something. But that statistic has been in place for many years, and it's good. Of course, we want to get it down. Verbal abuse and threats and intimidation can be more impactful than actual physical assault. I knew of a year that one of our hospitals had two people that were out for many, many weeks from constant verbal abuse from long-term patients that really had a major effect on them. That there was more lost work time from that than from any physical injuries. So never underestimate the impact of verbal abuse and threats. Threats, when people feel threatened, it is so amorphous sometimes and so scary that it can have a drastic effect. I've been threatened myself over my career numerous times, sometimes online, and that is pretty damn scary. Um, the aging population has an effect. There's a lot of unintentional violence in healthcare. That unintentional violence can be people coming out of anesthesia. It can be people with head injuries. It can be people with autism. But there is a lot of unintentional violence these days from people with advanced forms of dementia or Alzheimer's, particularly during the sundowning period. And that is very tragic because it's very hard, it's hard to understand. It's sad, but still it needs to be controlled because people can be hurt. I have seen, 85 and 90-year-old people definitely hurt staff in significant ways. So we have to know about that. We have to understand it. We have to manage it. There's more and more contraband brought into hospitals in this country. There are more weapon detection systems being installed. Some have been uninstalled because they don't work, or people feel that they're a false sense of security. So there's pros and cons with weapon detection systems. I have tested them when I've done consulting projects, and I've brought simulated guns that with the exact same componentry of a real gun not set it off. I have also seen underwire bras set them off. I have seen them set off and nobody doing the right kind of search afterward. So there's a lot of issues around weapon detections, and they're not all good, they're not all bad. It depends where people, when they put them in, often put them into emergency departments. But the shootings that have taken place in hospitals, and again, they're rare, but for the most part have not happened in emergency departments. They've happened in inpatient settings or in other satellite facilities. So I always worry about people putting a metal detector in one door when if somebody wants to bring a gun in, they would probably just walk in another door. There's substance use increase. We've seen that a lot since the pandemic and just in the wake of what's going on in our communities. And staff risk when responding. I mean, fentanyl is very serious if someone were to get exposed to it. We've seen a lot of a myriad of mixed use synthetic drugs these days that are scary. And so it's important that particularly our ED staff get trained in what these are, what they look like, what to do if they see anything that could be concerning to anyone else. The lack of psychiatric and skilled nursing facilities and practitioners in a lot of states, Massachusetts being one of them, is a huge problem for length of stay of mental health patients, sometimes in our psychiatric units, but oftentimes in our emergency departments for days, sometimes weeks on end. We've seen that across the country. Now, anyone sitting in a gurney in an emergency department, maybe not even in a room, but in a hallway, who were there for several days would probably escalate even any of us. So you can imagine what happens when there are no places to put people that need certain levels of care. We used to have a lot of forensic psychiatric facilities in Massachusetts. We don't have that anymore. A lot of states are the same. So this is a serious problem that I hope many people are working on to address. Visitor noncompliance is problematic, with people being a lot more on the edge than they used to be. You can see it in traffic, you can see it in lines in supermarkets, you can see it with people just not having the level of patience perhaps they used to with what's going on in the world. This can be a problem, particularly when visitors feel their patients aren't getting the care they need or getting as much care or need to be given released or whatever. The good news with visitor noncompliance is it's a lot easier to invite visitors to leave and to not allow them to be into your facility. Next slide, please. Other trends, we never years ago terminated patients. Naturally, with IMTALA and other things, we can't terminate patients that are critically ill. But if patients are continuing to be extremely problematic or posing a risk for other patients or for staff, there are times where we put together a group of people, and we should, in all hospitals, to look at if a patient should be terminated from care, maybe given a recommendation for somewhere else. There can be disparate or inadequate training around conflict or violence, and I'll talk about training. We always try to balance patient family focused care with protection and violence reduction. When we have visiting hours in our hospitals 24 hours a day, that is a security problem. It is. I understand it. I co-chaired a big committee years ago with our chief nurse on patient family focused care. And it's very hard to do both, to have it be in and out for family and friends whenever we want, and to let people be in patients' rooms. But it's hard if it's a double room. It's hard if the patient is needing a lot of care. It's hard for nursing trying to care for the patients. And it can be problematic for access control in the hospital because these people can be walking around all over. And at certain times of the day, you may not want that. Patient assaults on staff are rising. There's lots of legislative work being done across the country, including Massachusetts, trying to get much higher penalties for anyone who assaults a caregiver or a hospital worker, not only clinical staff, but non-clinical staff as well. I chaired for the past 8 years the Mass Hospital Association Committee on Workplace Violence, and we did a lot of work with the legislature to get some better laws on the books to help safeguard staff. It is critically important, and that is still being done. There's increasing numbers of behavioral health patients in lots of units, as I said, protection of our offsite facilities. At Mass General Brigham, for example, there's over 1,500 offsite facilities. Some are tiny, some are large, all over New England, and these are difficult sometimes to properly get people trained and protected. Theft of intellectual property. When people leave, they don't always leave the property that should be belonging to their hospital there. Theft of, and that can lead to reputation damages. And then, new drug diversion program and protocols, because drug diversion is a very usually rare but pretty serious event that can cost a hospital its license, can cost a hospital its reputation. Next slide. Finally, we've seen, and I mean this truly, a tsunami of anti-isms, of discrimination, of hate behavior in healthcare in the 40 plus years I've been doing this. And it switched. During 9/11, people were anti-Muslim. During COVID, people were anti-Asian because they thought it came from China. There's been major racial anti-isms at different times. There's been major LGBTQ discrimination. Now we're seeing an epidemic of anti-Semitism with a 500% increase in the last few years across the country. All of this transcends and transposes into our healthcare. And it really has an effect on people when someone is called a name or a slur or has a swastika left on their wall, or it has a hijab pulled from them as they're walking down a hallway, as has happened. Any of that can have a huge impact on not only the person who's victimized, but other people that are working with or close to the people. Staffing issues, there's a lot of compassion fatigue right now. People are tired. There's been a lot of financial cuts in healthcare across the country. People are working harder. They're doing more. Staff safety versus patient care, longer lengths of stay impacts everybody. Activist activities. We see that in the country politically, and all of those transcend into our healthcare organizations and our parking lots and outside our healthcare facilities, even when they may have nothing to do with us. We know that when people do not feel safe at work, they leave a job. When they leave a job, the average cost for any, this is from the Department of Labor, for any job in this country, the average cost to replace that person is around $80,000 to $90,000. So we certainly want to retain our people, and those costs are in recruiting costs and retraining costs and productivity loss and all of that. So we never want to lose staff because they don't feel safe. We want people to feel safe and comfortable and confident in being able to do the work, the critical work they do in our organizations. We've seen increased protests and civil unrest. We see a lot of that in our healthcare space, and even 10 years ago, there was far less. That cyber attacks I mentioned, biothreat concerns, which many of you in emergency preparedness are dealing with, and understanding very well and trying to figure out how to mitigate and plan for that and all that's going on in our geopolitical landscape. Next slide. Potential impacts of healthcare violence. Nothing that you don't know now, but for the victim, it can be definitely compromised performance, absenteeism, workplace interruptions, safety concerns, health issues, mental health issues. Even if the violence they're experiencing is at home and not at work, they still have these impacts. For the work group, you can see that list of what might affect them. I often tell the story of years ago, I was called to a group of people. It was a group of information systems people. They were kind of freaking out, and I asked what was wrong, and they said that someone in their group had gotten uh, fired. And I said, but you were friendly with this person. What's the problem? And they said, well, the person has not been acting particularly well. And over the last several months, every time they'd go out for lunch or for beers after work, the person would say, I fantasize about killing someone every day. And they were petrified. And, I wanted to yell at them and say, why didn't you tell anyone that? But obviously they were scared, and they really were very worried about the person coming back or hurting them at their homes. Next slide. The potential impacts of workplace violence on an organization are great. Um, we had years ago, we've had a shooting at Mass General Hospital, a stabbing. We've had other things, rarely, thank God, for places this size. But even though those were so rare and isolated and handled, people worry. They worry about coming to work. They worry about coming as a patient. When you hear about something somewhere, you wonder if it's safe. For those of you who have kids in college, you look up the Cleary Act report, I hope, from the universities you're thinking about sending your kids to, because that has what are the security incidents that have occurred in that university or college. So the organizational risks, when you think about what happened to Brown University a few weeks ago, and I knew the security chief there, and I've known a lot of senior people there. Um, they have a tough situation because they had cameras everywhere except in that older part of the building where the shooting took place. But they're probably their tuition costs are going to go up because of all the costs they're going to have to spend, whether it be in lawsuits, whether it be in security improvements, whether it be in recruitment costs because people have already left there, etc. And then liability impacts. I do some expert witness work. I have for 30 years around the country on occasion, um, both for inadequate negligent security litigation in lots of different industries, not just healthcare. And the good news is if organizations show that they have made the right decisions and investment in security with strong security personnel who are well trained and smart and properly paid, and state-of-the-art technology designed to fit the risk, and good policies and procedure, and strong and continuing training for employees, then they often will not lose a lawsuit. If they don't have the right elements in place, they can be in really tough shape. And the average lawsuit, even settlement for a negligent or inadequate lawsuit, for security in this country is about $850,000. So it's not chump change. And if it goes to a jury trial, it can be far more. So it is very important that we ensure that we are achieving regulatory compliance, because security is very regulated in healthcare, and liability avoidance. And I work with organizations a lot on both of those so that they feel like they have, reasonable or standards that exceed reasonable standards, and that they are avoiding liability, and that anybody can sue, but that doesn't mean they're going to win, and that they are certainly complying with regulatory impacts. Next slide. If you have a security department, I hope in your organizations, use them. Make sure you are on close spaces with them before an incident occurs. Um, they can do all kinds of things you may not realize in terms of background threat assessments, investigative activities, customized safety plans, management of the perpetrator, if the perpetrator is a patient or visitor, um, liaison with outside agencies, whether it's police or DEA or FBI or Secret Service, if you're getting some public figures. But really, security departments these days, for the most part, are very sophisticated, very well trained. We have strong degrees and certifications, and there's a lot to it. It's an industry unto itself. So make sure you're managing that. Customized safety plans are important. On any given day, if you're, a good-sized hospital, you may have a few dozen people that you want to be what we call off scope. It may be they're a prisoner patient that you don't want anyone to know where they are, or a gang member. It may be a patient who's been a victim of domestic or intimate partner violence, and you do not want the perpetrator to find out where they are. It may be, I remember a case that was mind-blowing, a woman who had come in, she had advanced metastatic breast cancer. She was an older woman. She was incredible. I'll never forget her. And she said she didn't want anyone to know where she was. She needed to be anonymous and off scope because she couldn't allow her husband to find her. And I remember saying to her and sitting with her myself, this was many years ago, and saying, is your husband violent? Are you afraid of him? And she smiled and she said, no, we've been married for 45 years. He's the love of my life. And I said, then why don't you want him to know where you are? And she said, because we're of a faith that we don't believe in Western medicine. And if he knew I was having treatment, he would be forced to have me leave here. And it would put him in a bad place because he'd have to get me out of the hospital. And I've decided I want this treatment and I don't want to compromise his position. I remember leaving that room. I'm not a big crier, but I actually completely got teary-eyed thinking about the love they must have and how hard it must be for her to not have him by her side. But there's all kinds of reasons people need to be off scope and need to be anonymous. And it is very important that we ask people when they enter the hospital, particularly for an inpatient stay, if they need any kind of additional security or protection or privacy protection. Next slide. Security response to conflict and violence. Again, I beat myself to this slide, but you can see what I'm talking about with customized security planning, doing a risk or threat assessment for someone who you may know of that may be a person who has been a risk, who has been a criminal, who has been a sexual offender, perhaps. It is important that you get security involved. So not to in any way stereotype someone, but to know what level of risk you may have posed to you, so you can just take appropriate action to take care of that patient fully and carefully and justly and equitably, but also that you're protecting your institution. Sometimes people want to press charges for someone that has victimized them. They may need you to go to court with them. It's a very scary situation. It can be overwhelming. So by having security go to court with someone or escort them there, be a liaison, be a safety pillar for them, for domestic violence victims, and help them find a place to go and maybe take them there. That kind of thing can be unbelievably enriching. I have people that send me letters decades later of what the work that our department did for them meant to them being able to finally get out of a very, very, very abusive relationship and be safe. Multidisciplinary groups are important. We're going to get to that next. Next slide. So here are some, you always need to have proactive programs. There is no one size fits all, as I said at the beginning, and I'm going to repeat that. There's not one way to combat violence. It's a confluence of a whole bunch of different ways. You have to have proactive programs. Here are some that we have put together. We put together when I put this together at MGB fairly recently. What the proactive programs, these are just some examples. These are not what you all have to do, but these are just examples I thought might be valuable for you. Police and security examples, patient care services, what they do. Some people use the ABRAT score to determine a level of risk, or the Brosset tool to help with that. There's different tools now that can help assess inpatient or emergency department patient risks. But you need to have a lot of collaborative approaches. Human resources can get involved and should get involved in a lot of ways. New employee training, harassment training and reporting, so that people feel comfortable that there's not going to be any fallout if they do report something, that they can be kept anonymous. That there will be no retaliation, all of that. And then collaborative groups. I can't stress enough how important it is. This isn't, it takes a village. This is not an emergency preparedness or disaster planning people that can do this alone, or security people that can do this alone, or risk people that can do this alone, or physicians or nurses. These have to be collaborative groups that get together and work together and use each other's expertise and use each other's intelligence to figure out the best plans. And sometimes these are customized plans. Sometimes these are, good planning in advance, and campaigns to help everybody realize, going back to my continuum, that they have to be in the middle. They have to be empowered. They have to be educated, and they have to think about security, not dwell on it, not be scared by it and their own protection and their own safety, but not be at complacency either. Next slide. You also have to have a reactive approach and reactive responses, and some of these are the same. But when that unforeseeable happens in a place where there is a major incident, it could be a kidnapping, it could be a hostage situation, it could be a drug diversion, it could be a cyber attack, it could be a major assault, it could be somebody coming in with a weapon and brandishing it. You need that emergent response. Dr. Johnson was just a duress alarm that we had at Mass General Hospital. Everybody in most hospitals have their own duress or code or response, and that should be used selectively and carefully. People need to be trained what that is. And again, reactive responses and reactive planning, more importantly, so that there has been planning and training and preparation, drills, etc. for some of the reactive responses are important. In small places that may not have security, some of our ancillary sites and some of our urgent sites, people that work in those sites need to be trained with good training on de-escalation and how to get help when they need it, but de-escalation tools themselves, and how to convene each other when there's an incident that may be going on. Next slide. I want to make sure there's time for questions. I can't tell you how important I think employee education is. It's the cheapest and the most effective way to mitigate and diminish violence in healthcare, in my opinion. When people are trained, it is statistically proven. I've done studies, we've done studies, that they do not get injured when they are properly trained, and they can de-escalate incidents so that other people do not get injured. People always say, I don't have time for any training. I don't have time for that 4-hour program. They have to make time. And that training can also help people in their personal lives. These are just a variety of programs that have been offered in different places I've been and worked and suggested. And some of them are, far less important perhaps than others, but certainly violence de-escalation, behavioral recognition is important. Active shooter training is important too, but not as important as the violence and de-escalation. A lot of people are victims of identity theft, so we offer that sometimes, workplace and domestic violence, and you can see the rest. Next slide. Protecting people from even milder forms of violence, whether it's threats or bullying. We talk about with bullying, how to be a bystander, how to be a good bystander, how to go sometimes just stand in people's space who may be being abused verbally so that they do not feel alone in helping them in some way. This is everybody's responsibilities. You know, we're all brought up to be polite and hold doors open for people. In healthcare, you cannot hold doors open for people because you could be letting the wrong person in with nefarious intentions in a place that you do not want them to be. So we have to retrain people that they simply can't they can't hold doors open, because we know when that happens, that's often how people get into places and do bad things. We need to make sure people know all of the services and supports that are open to them. It's important that I think people have staff meetings that you bring in some of these specialist security, risk, emergency preparedness people to talk about what supports are in place, what tools are in place, what people should be thinking and doing. And certainly doing disaster drills, functional drills, tabletop drills. Not all the time. It takes a lot of work, but occasionally, so people can get the feeling of what it would be like if something were to happen, if someone were to come in, God forbid, with a gun, or if someone were to grab somebody as a hostage, or if somebody were to just start going crazy in a particular unit or medical practice. People need to understand what that feels like and what they would do. Because if they haven't practiced what they would do, if they haven't practiced with mental conditioning, they won't be able to do it. We do a lot of work on mental conditioning, having people close their eyes and imagine what they would do. Perhaps if someone broke into their home in the middle of the night, people think they would know what to do, but in that instance of being petrified, you would not be able to do what you think you should do unless you've practiced it in your head. Grab my child first, lock the door next, grab my phone, open the windows, start yelling, dial 911, whatever your order would be. If you've practiced that in your mind over and over, that's when you're able to do it. But all of this is everyone's responsibility. It takes a village to be able to have a safe, effective, comfortable environment for staff, for patients, and for visitors. Next slide. Your commitment going forward as a person who is trying to help do this work and help people, and you're doing God's work, all of you, in this work is so hard in healthcare these days. Anybody's work in healthcare is hard. Certainly anybody working on emergency EMS work, emergency preparedness work, security work, risk work, certainly clinical work. We just, you should be patting yourself on the back every day and knowing what you're doing is just more important than anyone could imagine. We need to be constantly looking. This is never going to be solved. We're never going to get there. This is always a work in progress. I hate that, but it is. And we just have to keep pushing it, because the vulnerabilities keep changing. And sometimes things get better, and other things we're saying, oh, we never had this before, like the threats that we've seen against gender affirming care clinicians, etc., or like other kinds of things. We need to benchmark with others and seek innovative preventive programs and solutions. We don't have to do this all on our own. I do really recommend having outside consultants come into your program on occasion and look at what you're doing. They'll find things you haven't seen. They'll also see things you have seen and tried to get approval for, and sometimes by having someone from the outside come in with some objectivity, you can get what you need a lot quicker. So use, people like me or other people. There's a lot of people that do consulting that are very good to help, look at a particular problem or a particular facility or a particular unit or your workplace violence program, or writing a policy manual. Improve data collection, trending, and analysis. You can't get anything if you don't have data around it. It's a pain. We all know that, but you really need to have data, which is why you need to ensure people are reporting everything. And by everything, you have to specify what it is you want them to report and how you want to report it. And they need to know something's being done about it. We need to understand ratios, not only of clinical staff, but of the right support staff, whether it's EAP, whether it's psychiatric staff, whether it's security staff, whether it's emergency preparedness staff. We can't do this job alone, and we know we're not going to get all the resources we need because that just doesn't exist in healthcare right now, but we need to ensure we get the most important resources to be able to help with whatever problem you're having. And you won't know really how your trends are going if you don't do good data and you don't look at that annually, or at least annually. It may be that the work in your emergency department, it's lowering in certain areas of the department, but growing in others. It might be that you see that days and nights your assaultive and difficult behavior is going down, but on evenings it's not. Seasonally you might see some interesting trends. It's important you know those trends. A continued strong focus on increased training. I've said that several times, I know, so I don't mean to be redundant, but it really, really will affect your whole empowerment, your peace of mind by employees, and your statistics. And you've got to continue to prioritize staff safety and reevaluate patient family focused care and overall balance of care. It's critically important to the overall protection of your facilities. I think that may be it. Next slide. Future challenges. You know those future challenges. I've mentioned them all. The anti-immigration conflict with ICE, with the politicizing of everything these days, and the bifurcation and the chasms between people politically are creating a lot of violence. We never saw that in years gone by. So we have to be aware of that. We need to think about, none of our facilities have enough space, what that means. Think about the experiments they've done with rats in cages when they get too crowded. We need to think about space. We need to think about how we put space, how we spatially design offices and patient care rooms and other kinds of things. We need to think about how to report increased thresholds for tolerance, need to decrease. And the emotionality of environments is increasing. And it's important not to react to people who are lay people just because they're scared and just throw up solutions that may not be the right solutions because people get scared. It's important to do that with good, I don't want to use the word scientific, but good evidence of what makes sense. And there's so much research that's been done in all of security and safety and protection and enterprise security risk for healthcare. There's really a lot out there and a lot of people that are very expert in it. Next slide. Ultimately, and this is the last slide, the best way to prevent and mitigate conflict and violence. And again, always use the word conflict. It's not just violence that you're dealing with. It's mostly conflict, but that can be very, very, very impacting. It is a corporate culture that engenders respect, open communication, no retribution, effective supervision, and employee involvement, participation and development, not just power and authority. Preventing workplace violence equals zero ignorance, as I said earlier. And again, utilizing and collaborating with your departments like emergency preparedness, disaster planning, business continuity planning, risk, even your financial departments, as well as police and security, and certainly your clinical teams and human resources and occupational health and EAP, critically important. So I'll stop here. I think, this is sounding very like, I know it's not, I hope this isn't a downer. It wasn't intended to be. I think there's a lot of really good progress being made in hospitals. I've been in it a long time and I've seen tremendous progress, really good stuff. But as much progress as there is made, there is still a tough situation out there because of the factors that we mentioned. So let me turn it over to Jen, and she's going to facilitate some questions. Thank you so much.
Beautiful. Bonnie, thank you so much. I think all of the points that you hit today, from our risk and our threat profiles to just the importance of data and how we create both a safe environment that's built around trust, empowering, and training, I think is just so critical for all of us, whether you're in healthcare, public health, first responders, and elsewhere. And so we're definitely going to encourage anyone who has questions, please feel free to drop it into the Q&A or the chat function. Bonnie, I'd actually love to kick us off with, one of the themes throughout this was really, as you called out, this work truly takes a village, and recognizing that we have members on today's webinar who really are cross-sector, healthcare, public health, EMS. Would love your thoughts in terms of how, if you're in healthcare, how do you align and partner with your community partners, or how should you be doing that in terms of working with law enforcement, EMS, and public health agencies to overall strengthen our healthcare security programs, but by proxy, strengthen our broader, whether it's city or regional readiness?
Sure. Great question. The last thing you should be doing is partnering with these people during a disaster. You need to be on a perpetual basis getting to know your partners in the public safety, in the public health world, in the law enforcement world, in the EMS world. You need to hold lunches or meetings on occasion, quarterly, whatever you want, where you have a variety of people from all of the agencies that you want to work with, that work with each other. So you're coming together, you're bonded, you're talking about the issues of the day, what is challenging every agency, what people can do to help each other. And you'll find there is so much redundancy in terms of issues and collaboration, and people can then find solutions that they haven't thought of. So I can't stress enough bringing together people to, first of all, learn your facilities, to understand what they are looking like, so they're not coming in during an emergency saying, where do I go for this? To understand your issues, for you to understand what they can do and cannot do to help you, and how they would propose that you access their help. That couldn't be more important.
Thank you so much, Bonnie. I think that's not surprisingly just so spot on in terms of, especially in a world where we oftentimes don't see each other face to face in ways in which we used to, creating those opportunities to really foster and forge those relationships is important. Bonnie, as you're seeing in the chat, there's many people who obviously want to speak on this, I think, with you even outside of this. I'm going to flag one question around training and toolkits. And so the question is, do you recommend any specific toolkits to hold a drill focusing on workplace violence with the employee being the aggressor?
DHS has some toolkits out there. FEMA used to have one. I'm not sure. I haven't seen theirs lately. And then there's some private organizations that have a toolkit. And there's many that will put together, have a toolkit and will customize it for you. I think that is very important to get a toolkit, but when you're thinking about exercising at your own facility, you really want to customize it so that it's particularly salient for you and for the issues you want to cover. You can't cover everything in one drill. We all know that. So I also am a big believer, and Jen has heard me say this over and over, in doing drills off hours and weekends, because unfortunately that is often the time we have things happen and we don't have a lot of people around that may be as well trained on what to do about it.
Perfect. You're getting a lot of different thumbs up around things. This is great. So
Thank you. I'm not seeing any of the chat for some reason.
That's okay. I'm toggling back and forth between the chat and the Q&A for us here. So another question/comment that's come in, which just says, remember that law enforcement normally only are in or frequent certain areas of your building during an event. Let me see, during an event, your facility will likely be new to them, and they will be heightened as well as stressed and likely have little to no information they are responding. So helping them help you is vitally important. So I think Scott's point here, Bonnie, goes back to when we were talking about relationship building and what that partnership is.
Yeah, that is such a good point, Scott. And what can help is if you have prepared something that you can send to your police, your responding police departments in advance with some maps and with some of your high risk areas. Obviously, if you can tour some of the senior leaders, that's great too. But at least they have that. They have how to get around. They have where they, where they might need people to get into, what's where. And if they at least have that during an event, hopefully they've maybe looked at it before, but if they can grab it during an event, that is very important.
Absolutely. And we have Jason shared here in the chat that he hosts monthly meetings with his law enforcement leaders, local PD, sheriffs, and EM Fire, and it's been a tremendous asset. And so I think similarly, just amplifying the criticality of what we've talked about.
So that is great,
So
Jason, that you're doing that. That is so important. And people enjoy it. They want to meet with like-minded colleagues that where we can all let our hair down and talk about what's really going on and how to help each other.
yeah. So Bonnie, as we head into our final minutes, one thing that I did want to ask is, we've mentioned really the criticality of reporting and tracking events and what that looks like. And so are there any strategies that you found most successful that really has created a cultures where our teams feel comfortable reporting incidents and it really just becomes a part of that muscle memory? Are there things that we can do to improve or, make our staff feel confident in reporting when events happen?
Yes. I'm just sending my email in the chat. Um, I think the most important thing is to give people a very clear list because they don't understand that if somebody's just swatted them, that's okay to report it. Or if someone's called them a swear or a racial epithet or any other thing, that they should be reporting it. So they need a very clear list. So they know that they're not being a baby. A lot of people say, I didn't report it because I didn't want to sound like I couldn't handle it, or I was a baby, or I was weak. And really reinforcing for people that it's not only strong to report it, but it helps everybody because that person could escalate even more and get worse with someone else, and that they don't deserve to be treated that way as a healthcare provider. So constantly reinforcing that message, making the reporting um, uh, the way to report easy, not hard, because no one's going to do it if they have to go through 3 pages of a template. So making that process easy is critically important, and that's what I would say would help. And giving people
Bonnie,
reinforcement for reporting, getting them some follow-up, or just even if the follow-up is just, we are so happy you let us know that this is great.
I think that's just so useful, right? And the more that folks sort of see what that looks like, we hear a point in here from Jason that it's, he makes it a point to tell his caregivers and his evade or active threat trainings anything on workplace violence, that it is not up to someone else if you felt threatened, harassed, or something similar, and that it's a personal decision. And I think that's a great way for us to, as we hit the 1 o'clock hour, for us to wrap up, and that, what we're talking about today truly is a community. And so, Bonnie, let me just thank you again for joining today's webinar and providing just such rich resources, as well as just context and information around just the importance and criticality of this work and different approaches that we can all consider as we think about this within our day-to-day work. And so
My
thank
pleasure. And thank you all for being on. I really appreciate it.
you all. We hope you have a great weekend.